Good afternoon, everyone. iTech India welcomes all the participants for today's regional distance learning seminar session. Today's topic is HIV and hepatitis co-infection and HIV and leishmaniasis co-infection. And the speaker is Dr. Nilima Shah. Dr. Nilima Shah, ma'am, is the professor and head of unit with the Department of Medicine, BJ Medical College and Civil Hospital, Ahmedabad. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, iTech, for giving me the opportunity. So we'll start with our session regarding the HIV and hepatitis co-infection and HIV and leishmaniasis. Why it is important? So if we look at the data worldwide, hepatitis B worldwide last year 2019 data are available. The occurrence epidemiologically, if we see, it is almost 30 lakh approximately, and for hepatitis C it is 6 lakh. So all over the world, hepatitis B and C is this much predominant. If we look at the death in 2019, almost 8 lakh people succumbed with hepatitis B and 3 lakh with the hepatitis C. So this is the simple hepatitis B and C infection. And when we discuss it with the HIV, the route of transmission is common. So if we look at the hepatitis C, it is almost 6.2 and hepatitis B is 7.6. And mainly this is present in IV drug abusers, if they have a sex with the man, and especially, so similar routes is there. So viral hepatitis is an increasing cause of morbidity and mortality. Why it is important? Hepatitis B is associated with a more problem with cirrhosis, hepatocellular carcinoma, and the mortality. So progressive liver disease is more common, and with HIV is also not responding well when there is a hepatitis B infection. So if you look at the slide, the concurrent or sequential infection, so it is more when there is a co-infections occur. So why we are worried for this thing, and how we have to, these are the infection. So if is there any preventive measures as available that we should look for? So that from then only we can decrease the morbidity. So we'll look into the another slide later on. So first with the hepatitis B co-infection. So estimated national serosurveillance of hepatitis B is 0.95%. When one person is having hepatitis B, suppose acute hepatitis B, that is a new onset of hepatitis B, that may not be icteric or may not be symptomatic. So this is more dangerous because person is having hepatitis B, but it can be asymptomatic also. Or if it is acute hepatitis like hepatitis A or E, they are transmitted with the fecal-oral route. In that case, we have to wait for 6 months. If person is not clear with the hepatitis B surface antigen, then patient may go into the chronic stage. So risk of developing chronic infection is in 90% it is perinatal infection. So here the things we can have something to go with the preventive measures. So infection during first 6 months to 5 years, this is 20 to 60%, and adulthood only 5%. So this is a more chunk of the things where if timely vaccine is given, if hepatitis B positive mother is there and is giving birth to a child, then from 0 we have to do the vaccination from 0 dose. So what is the natural history? When there is a HIV with hepatitis, then progression of HIV is also fast. So there is a faster CD4 decline. slower CD4 recovery following ART, more incidence of AIDS and non-AIDS event. There is an increased rate of ARV toxicity because most of the ARV drugs are giving toxicity with the liver. So there is a even more chances of immune reconstitution hepatitis as well as of a iris also. If we look at the patient with the hepatitis B, if only hepatitis B and with HIV, then there is a chances of rapid progression of the cirrhosis, rapid progression to the hepatocellular carcinoma. There is a higher liver related mortality as well as the treatment response. What we give the treatment to the hepatitis B patient, they also have a decreased response. So it is a bidirectional. HIV is also having some problem. Hepatitis B also, if they both together. So what we can do? So how to select or how to screen? So all newly diagnosed patients, this is very important statement for all of us, that all newly diagnosed HIV should be screened for HBsAg antigen. So when there is a HBsAg positive, then we have to start the treatment accordingly. Those who found HBsAg positive, they evaluated further according to the technical guidelines for the management of the hepatitis B, because we have a National Viral Hepatitis Control Program, that is NVHCP. Almost this program was started in 2018 and they have linked the thing with the ART centers. So what we have to look for as a doctor? Besides routine clinical evaluation, when patient comes to us, always look signs for the cirrhosis. So what are the signs of cirrhosis? Yes, we have this thing we have learned in our undergraduate days also. That is, a patient is having jaundice, may not be present, but having jaundice, hemorrhage, anemia, spider angioma, Palmer erythema, fatigue, clubbing, gynecomastia, testicular atrophy, parotid enlargement, liver flaps, flapping tremors. Suppose patient keeps the hand like this, then there is a flapping tremors. So these are the class 1 type of the hepatic encephalopathy. Caput medusae, that is prominent vein around the umbilicus, ascites, edema, longitudinal vein along the abdomen, hepatomegaly, hepatic brew, venous splenomegaly. Differential we can go with the later on, but at present we have to look for the signs of organ enlargement, means hepatomegaly, ascites, as well as we have to look for the jaundice. And patient can be alcoholic, they may have a cirrhotic, but then that is why if patient is having HBsAg positive, these all signs comes to important regarding the treatment for them. How we investigate? Routine hemogram and chemistry, means hemoglobin, there can be a anemia, total count may be low. If there is a more of a splenomegaly, then it could be a pancytopenia also. So low HB, low WBC, platelet low. Then we have to look for the liver function test, ACPT, OT means ALT. Prothrombin time can be increased. Alpha fetoprotein, this investigation is mainly for the hepatocellular carcinoma. Ultrasonography, if it is available. Upper GI endoscopy, whenever it is indicated, means if patient is having signs of bleeding or esophageal varicose bleeding, then endoscopy is required. Virological examination should include HBV DNA quantitative. This is the viral load, so that also can be included. Now, how to stage the cirrhosis? Here, for the treatment, like it is not like the hepatitis C. In that, we have to standardize the treatment according to the staging of the cirrhosis. Here, whether it is decompensated or not. Suppose if you don't have an ultrasound at your level or upper GI scopy, what are the things that can be done, like a non-invasive technique? So earlier it was liver biopsy, then Metaway score. But nowadays, elastography, that is known as fibroscan, that is also not available at everywhere. So how we can do the other things? In fibroscan, we measure the liver stiffness to see the liver cirrhosis. But the other thing is a non-invasive technique like a APRI, that is AST to platelet ratio index, and fibrosis score scan, that is FIB4. Now, if I go into something little bit into the detail, FIB4 is a score that is online calculators are available to see the score. In that, you require in FIB score, it is age, then AST, ALT, and platelet. The formula is available. You just feed your findings. If it is less than 1.30, then there is a low risk of fibrosis. If it is more than 2.67 ratio, then it is a high risk. If it is in between, suppose 1.30 to 2.67, then it is an intermediate risk. So we can clinically judge that whether patient is having the end stage disease very much decompensated or not. Likewise, in a APRI also calculator is available. Then childpox scoring, the last one. In that also 5 components are included. For that also calculator online is available. These are the ascites, hepatic encephalopathy, bilirubin, albumin, and prothrombin time. See, these are the investigations that can be available at the district level also. So the score is divided into A, B, C. If it is 5 to 6, then the score is A. In that case, it is a compensated disease. If 7 to 9, that is B, that is decompensated, and 10 to 15, that is C, is very much decompensated. So these are the little detail of the scoring. What is our goal is how to start the treatment. All HIV, HBV co-infected patients to start with the dual treatment, that is anti-HIV and HBV therapy, irrespective of CD4 count, HBV viral load, and status of the liver disease. This will come into hepatitis C, not in the hepatitis B. So here we start with though we have done the scoring, we know the compensation and decompensation, but with that we'll come to know whether patient is developing jaundice due to some other side effect of the drugs, or it is because of the disease itself. So all patients should be linked with the designated center. Suppose in Ahmedabad we have a NVHCP screening and everything in our ART center only. So all patients are screened, they are further diagnosed, and then we can start with the treatment. The thing we have to keep in mind that for the hepatitis B, tenofovir and lamivudine, that is the drug of choice for the hepatitis B patient. So when we start the treatment for HIV, we have to include these 2 drugs. So that's how we cover both the infection. So to ensure the provision of the drug for hepatitis B, that is tenofovir or entecavir, and access to the investigation necessary for the monitoring of the response. And we have to see the cirrhosis of liver as well as if alpha fetoprotein available or USG, then the hepatocellular carcinoma. The recommended drug, NRTI drug, is a tenofovir with the lamivudine, or that is a amitriptyline. So we have to go with these 2 treatments. So all the people co-infected with HIV and HBV should be therefore receive tenofovir based regime in combination with the lamivudine. Or suppose if you want to change the ARV drugs because of some resistance or toxicity, then also tenofovir, lamivudine should be continued with the new ARV regime. So these 2 things is very important, that when we want to change, because abrupt discontinuation of this treatment will lead to the reactivation of hepatitis B, hepatic flares, and in rare case, it will go with the hepatic decompensation. So this is very simple thing. We all are doing HIV treatment, first line, second line, third line. So we all know. But suppose there is hepatitis B infection, then these two things we have to keep in mind. If we want to stop the tenofovir based again treatment, then it should not be done. So when to start? All people diagnosis with the HIV should be given treatment, regardless of the CD4 count or population of the means newer guidelines. What is the choice of regime? The first line is our fixed dose, that is a tenofovir, lamivudine, and dolutegravir. What is the preferred one? If there is a tenofovir toxicity or contraindication, then abacavir is added. Otherwise, so for HIV and hepatitis B combination, this regime is to be start. Entecavir may be start when there is a toxicity of a tenofovir. So what is the alternative regime? The same thing. If it is a renal toxicity, then we have to go with the entecavir. What is the second line regime? Again, the same thing. Lamivudine, tenofovir should be continue in case of a hepatitis B. Ideally, lamivudine alone is not given because there is a resistance developed in 50% of the patient after 2 years and in 90% after the 4 years of the treatment. So it should be given with the combination. Now, what is hepatic flare? When there is a tenofovir is substituted with the zidovudine, the treating physician shall recognize the fact that lamivudine is the only active drug in the ART regime, and another agent active, it could be considered according to the guideline of the NVHCP. So timely referral is to be done. Hepatic flare typically present as a unexpected increase in the liver enzyme, that is ALT, AST, and symptoms of the clinical hepatitis means fatigue, nausea, abdominal pain, jaundice within the 6 to 12 week of the ART. So the flare may be difficult to distinguish from the ART induced toxicity or from the whether it is because of the drug. So drug active against the HBV should be preferably continued during this suspected flare. If it is not possible to distinguish because of the serious hepatitis B flare from the grade for toxicity, we have to continue, and ART should be stopped till the patient is stabilized. So hepatitis B will continue, ART may be stopped till the patient stabilized. So this is when patient is having already infection, but what is to be given for them when there are newly diagnosed HIV and they are negative? So our work is over here, how to prevent the disease. Infant born to the hepatitis B positive woman. So hepatitis B vaccine is to be given. It is showing lower response in a person with HIV or with a low CD4 count. So normally we give 3 doses. Here you can even go for a 4 doses also. The infant who born to hepatitis B positive woman need to be immunized within 12 hours of the birth. Like just BCG and polio we give, like in that kind only, we have to give 0 dose, followed by 1, 2 and 6 month doses, that is 10 microgram intramuscular, and we have to give hepatitis B immunoglobulin also 0.5 ml intramuscular. So this is very important aspect. If already patient is having HBsAg positive and if person is having past history of hepatitis B with anti-HBs antibody titer more than 10 microunit per ml, these patients are not required to be given preventive measures. So another part is hepatitis C. Here also the same way, route of transmission is same, mainly with the IV drug abuses. The more problem with the hepatitis C, you don't have so much of a antibody or antigen like in a hepatitis B. So it is sometimes difficult to see. We have to go with the HCV RNA alone, and we have to decide whether to start treatment or not. So HCV accounts nearly 12 to 32% of all cases of liver cancer and 10 to 20% cases of cirrhosis. Both of which have higher treatment cost and very poor outcome. National serosurveillance of hepatitis C was 0.32%. Approximately 52 to 130 lakh people estimated to be infected with hepatitis C in India. This is a very big amount. So what will happen? Suppose person is having acute hepatitis C. This can be with jaundice, without jaundice also. From that, only 15 to 45 will resolve. Rest go into the chronic stages. From that, 85% may remain stable, but 10 to 15% will go into the cirrhotic changes. Then cirrhosis will progress slowly and go into the decompensated phase, and hepatocellular carcinoma 2 to 4%. So this is more dangerous also when there is a non-icteric phase and going towards the hepatocellular carcinoma. Sometimes we also see in patient, like patient is having a cirrhosis. We investigate and patient found to be having a hepatitis C positive. So again, what is the impact of co-infection? Rapid progression of HIV as well as impaired CD4 recovery, and with the HCV also the same thing. Cirrhosis is progress rapidly, decompensation also rapid, and carcinoma also. So this is also double way. You can say that HIV and HCV again the same thing like a hepatitis B. So how to go with this? How to overcome? So it is recommended to screen all person who are using IV drug users, and those with a history of multiple blood and blood product transfusion, or those with the raised liver enzyme more than 2 times of the normal upper limit of the normal, and if you have a strong clinical suspicion. The test is used to detect anti-HCV antibody. This anti-HCV antibody developed as a part of acute infection. They persist throughout the life. Among those who are infected, 40% may clear the virus, but still some have a persisting antibody. So they just have clear up the virus. They don't require any medicine, but still antibodies are there. So only with the antibody, if HCV antibodies is positive, we are not starting treatment because they have own complication with the toxicity of the drug, even cost also. So hence, in person who have an anti-HCV antibody, a nucleic acid test for HCV RNA to detect the presence of the virus to confirm the diagnosis of chronic HIV infection. This was not with the HBsAg positive. This is with the HCV because antibody may remain persistent without having viral load significant. So how to go with the clinical evaluation? Again, same thing. History, physical examination for the jaundice, hepatosplenomegaly, ascites, cirrhosis, decompensation. Lab test also same thing. Liver function test, prothrombin time, complete hemogram, even albumin also to be included, alpha fetoprotein, etc. The same ultrasound, we see the liver size, whether is there in nodularity, endoscopy to see the varices or not, and fibrosis with the invasive like biopsy, that is now we are not doing, but non-invasive method, if scopy or anything is not available, then told you it is a FIB4 or child's score, that can be calculated by the even with our from the mobile also. So how to go ahead with the treatment? Previously, interferon and ribavirin was a combination of the therapy given to a hepatitis C patient. But nowadays, the newer treatment is a directly acting antiviral, that is a DAA. So, if we see the directly acting 3 or 4 drugs are available, so that can be directly started. If patient is having a cirrhosis, decompensation, then other the duration is also increased. That will come into the next slide. The SVR, that is a sustained virological response. It is good with the DAA based therapy among the people with the HIV as well as the without HIV. So that's why directly acting antiviral therapies are started. So all PLHIV should be linked to the treatment model treatment centers under the national guideline programs, and they provide free evaluation and treatment for all people who are infected with the HCV. The decision to start ART among the people co-infected with the HCV should follow the same principle. There is no difference in the mono infection or it is with the HCV. So like it is not that first you give the for this thing and then you start with the therapy. This is a table showing testing algorithm of a viral hepatitis patient with a HIV. Suppose some patient comes HIV positive patient with a hepatitis. So how to look at the things? I told you previously that it can be hepatitis A, it can be hepatitis E, it can be hepatitis B or even C. These two are our more concern. This is if anti-HEV or anti-HEV is there, then it is hepatitis A positive, hepatitis E positive. Then we are not worried because here antiviral is not required. But if it is hepatitis B, then we have to go with the things that if we go with the acute infection, then it is a IgM anti-HBC, that is a core antigen. If it is positive, then it is a hepatitis positive. If both is non-reactive, then and then negative. Otherwise, it is considered as a positive one. In anti-HCV, that is an HCV antibody, if it is positive, then HCV is reactive, antibody reactive. To start treatment here, again viral load is required. It is not that you just go with the HCV positive. If it is negative, then it's okay, negative. But for starting of treatment here, the viral load is required. So without jaundice, suppose if patient suspected patient, if you see, then again the same thing, HBV positive, HBV negative, then negative, report as a HCV, almost the same thing, but with jaundice and without jaundice. So what are the treatment options available? The following drugs are currently available: sofosbuvir, declatasavir, velpatasavir, and ribavirin. The treatment is currently recommended for the individual older than the 18 year of the age, and the place and choice of the regime is influenced by the stages of the disease, cirrhosis and no cirrhosis, and other comorbidity and complication. All treatment naive patient for hepatitis C without cirrhosis and complication, means almost 80% of the cases, are managed at a designated treatment center under the NVHCP, while complicated case and retreatment cases are managed at the model center. So these we have to remember. HIV with chronic HCV infection, it is present with the HCV RNA. We have to go with the viral load. If it is more than 20,000, then we go with the other if available. This we can go with a prenaturally FIB also. Now we can go with the things. So if patient is not having cirrhosis, then treat with a two drug, that is a SOF and DCV for 12 weeks. Then again go for HCV RNA. If not detected, then treatment is over within the 12 weeks. Here, if there is a cirrhosis but compensated, A, the what we discussed previously, what is ABC, then treat with the 12 week again with the valpatasavir. Then go with the again HCV RNA. If it is not detected, then treatment is over. If it is detected, then we have to refer to the higher center for further referral because they require some specialized treatment. So in general, clinical stabilization of HIV disease with ART is advisable before starting with the HCV, while directly acting antiviral for hepatitis C infection have a good outcome. It is important to bear in mind that there are important drug interaction between the ARV and this thing. So we have a different table is available in the next slide. The decision to start ART among the people co-infected with the HCV should follow the same principle, like in a previously mentioned. So the fixed a single pill, tenofovir, lamivudine, and dolutegravir for adults and adolescents. Potential harmful effect of ARV drug include their hepatotoxic effect, lesser in the newer one, but then also for most of the HIV and HCV co-infected patients, including those with the cirrhosis, the benefit of ART outweighed the concern regarding the drug-induced liver injury. So we have to give the ART. So this table is patient without cirrhosis, uncomplicated. For 12-week treatment is given with the decletasavir. If childbirth A means compensated, then it is valpatasavir for 12 weeks. If patient is having B and C childbirth score, we have to give them ribavirin 16 to 1200 milligram for 12 weeks. If patient is not tolerating ribavirin, then the same regime soposovir and valpatasavir given for 24 weeks. So this is also things to be remembered. So drug interaction, again we list the main thing what we give in a ART. 2 or 3 things I want to say. We have to monitor the toxicity of tenofovir, as well as here when there is a NNRTI is given, they are the soposovir and valpatasavir is not used. So these tenofovir toxicity we have to monitor, and these two things also we have to keep in mind. So how will you monitor? Regular monitoring of the liver and renal function when both the things are going on, means for hepatitis C and HIV. Additional monitoring for liver function in presence of cirrhosis. If there is a neutropenia, thrombocytopenia, and anemia, they require monitoring. So this is a very decompensated stage. So they require every 1 to 2 weeks of the monitoring. Prevention, like hepatitis B, HCV vaccine is not available. So we have to go with the our PPTCT protocol for prevention of the hepatitis C. All drug users in strict maintenance of disposal of the needle, syringe, means all SARP, etc. in even at the healthcare setting, and safe sexual behavior. The third part of today's lecture is HIV and leishmaniasis. Leishmaniasis is not that common in Gujarat. Some cases are there in Rajasthan, but otherwise it is more predominant in Bihar state. So we are not seeing that much amount of the patient. But nowadays, because of the migratory population, suppose person is coming from Bihar and staying at Gujarat for some work and this thing, and suppose he comes with the infection, even they are the good reservoirs. So that's why this is important to look at. So this is a vector-borne neglected tropical disease. More than 20 species of leishmanias parasites are there. Three things can occur in leishmaniasis. It can be a visceral, so that is known as VL or Kala Azar, mucocutaneous known as MCL, and cutaneous that is known as CL. Estimated cases are high, 50,000 to 90,000 worldwide annually. In 2018, 95% of the visceral leishmaniasis new cases reported to the WHO. They occurred in Brazil, China, Ethiopia, India, Iraq, Kenya, Nepal. So even the good map is also available in the next slide. So annually, almost 1 million new cases of cutaneous leishmaniasis occurring. And 90% of the mucocutaneous cases occur in Bolivia, Brazil, as well as Ethiopia and Peru. In India, suppose if we look at the map, this is more than 1,000 visceral leishmaniasis they have reported, but not in all the states. In India, mainly visceral is there are small pockets of cutaneous leishmaniasis in Rajasthan, Himachal Pradesh, Kerala. Otherwise, main chunk of the disease is there in the Bihar. So it is almost 80% of the cases. So we have to look at the patient residence also. Though if it is coming for a once, then it's okay. If we are having a more of a follow-up and everything. The sandfly is a vector known as phlebotomus in a old world, means it is in Africa and in America it is known as a Lutzomia. So how the disease occur? There are two stages of Leishmania donovina complex, that is a promastigotes and amastigote. Promastigote, they have a flagella. Here amastigote, they don't have flagella. These are in the macrophages. So Leishmania donovina is the Indian subcontinent, and another is infantile, also known as Chagasi, that is in Europe and New World. So how the disease comes? Why this is important? Because from human, sandfly can transmit the disease. So when there is a sandfly takes a blood meal, there is a promastigote stage, and in when it inject again, it goes with the phagocytosis by the macrophage. Then there is a amastigote phase. They multiply in the cell, and in presence of HIV, they have a more fast multiplication. Again, with the fly only, they have a this ingested parasite. Again, they transport, go into the midgut and into the nose of a fly, and again the vicious cycle goes on. So two type of the transmission, anthropogenic and zoonotic. Anthropogenic means the humans are the major reservoir. In zoonotic, the dogs are the most important reservoir. So transmission of visceral leishmaniasis in South Asia and the Horn of the Africa, where the human with Kala Azar or post Kala Azar dermal leishmaniasis, that is PKDL. This is act as a major reservoir. Cutaneous leishmaniasis has a zoonotic transmission, except the disease caused by the leishmaniasis tropica. Because in previous slide we observed there are more than 20 species. So if this species is there, then it can be a different. The reticuloendothelial system of the body is affected when there is a leishmaniasis. So there is a high parasite load accumulate in the spleen, liver, and marrow. So when you don't have antibody in the blood, where we do find the leishmania, is from the spleen, biopsy, liver, or from the bone marrow. When there is a bone marrow infiltration, it will develop pancytopenia. Severe anemia also can occur due to suppression, hemolysis, and splenic sequestration, hepatic dysfunction, jaundice, and ascites. occur late. So again, the same thing comes in our mind that suppose hepatitis B is there, hepatitis C is there, then also there is a hepatic dysfunction, jaundice, ascites. The same. So differential is very important. Whether we are suspecting fever persistent, the clinical symptoms we'll discuss in detail, but almost the same thing. Thrombocytopenia, hepatic dysfunction, rarely chronic diarrhea, malabsorption also can occur. So asymptomatic infection, fever, anemia, splenomegaly, hepatomegaly, bleeding manifestation, jaundice, pancytopenia, hyperglycemia, and immunosuppression will increase the risk of secondary bacterial infection. So suppose your patient is coming with the hepatosplenomegaly, ascites, anemia, and having persistent fever in spite of some antibiotic, antimalarial, and patient is coming with that endemic area, and his liver markers are raised, but hepatitis B, C is negative, other is negative. Then if endemic zone is suspected, then we have to suspect the leishmania. The secondary infection, so tuberculosis, pneumonia, herpes, scabies, dysentery. So if all this is untreated, then patient may die. So this is the visceral leishmaniasis. We can make out the spleen. Use here means this is a umbilicus. So this is crossing the umbilicus. So it is a very big, huge spleen. Mostly occur in a chronic myeloid leukemia also. So this is very huge spleen. Incubation period is between, in visceral leishmaniasis, 10 days to over a year, even after infection. But more typically between 2 to 6 months. So core clinical features is what? Fever, anemia, weakness, weight loss, and splenomegaly. So when there is a fever and splenomegaly, the differential comes like a malaria. And if in endemicity, then persistent fever, then leishmaniasis. Other features are enlarged node, 1 to 2 centimeter, soft cough, watery diarrhea, pancytopenia, hypoalbuminemia. Again, the same thing, tuberculosis, differential, nodes, even HIV, less CD4 count. Then these all will have a mixed clinical features. Skin are dry, thin and scaly, and there is a hair loss. Grayish discoloration of the skin of the hand, feet, and abdomen, and face in light color people. If person is having already dark skin, then they may not have this typical dark color skin. But if they are having a little bit light color skin, so that's why it is named as a Kala Azar. So death occur due to opportunistic infection. What is post-Kala Azar dermal leishmaniasis? The macular, papular, nodular rays mostly on the faces, upper arm, trunk, and other part of the body as a sequel of visceral leishmaniasis in 5 to 10% of the patient. Usually appear within 6 months to a year after it has been cured. Patients with PKDL are considered as a potential source of leishmania infection. They require treatment. So estimated prevalence is 2 to 5.6%. It is not 2 to 5, it is 2 to 5.6%. Leishmania, mastigote survive and multiply within the macrophage. It is enhanced by the HIV co-infection and accelerated the progression of the disease. Compared to HIV negative individual, risk of developing visceral leishmaniasis is between 100 to 2300 times higher. So this is very, very high things. Means it is 2300 times higher in a HIV patient. What is the challenge? Co-infected patient have some immunological characteristic. Clinical manifestation may differ from HIV negative and resemble to other OI. So what we discussed means tuberculosis and everything. The atypical, when the mastigote in an unusual site, suppose it goes into the GI tract, oral mucosa, skin, in pleura, pericardium, lymph node, then KS lesion and respiratory tract in a co-infected patient. So this can be can also be affected. Parasitic dissemination to the skin in diffuse cutaneous leishmaniasis or throughout the reticuloendothelial system in a visceral and that is a organomegaly. Atypical parasitic dissemination and detect in with the cell-mediated immunity. So chronic and relapsing course with each patient typically experiencing 2 or 3 relapse despite of the proper treatment. Poor response to the standard therapy and lack of the antibody. They don't develop antibody. So it is difficult. So how to suspect? History of fever more than 2 weeks with splenomegaly and hepatomegaly, not respond to antimalarial antibiotic in an endemic area. So what we discussed previously. Then we have to go with the rapid diagnostic test, that is RDT. And we have to see whether it is positive or not. Sometimes this RDT test can be negative. So when there is a past history of Kala-Azar or there is a high suspicion, what we have to go? We have to find out the bone marrow, spleen aspirate to see whether is there any leishmania donovina is present or not. So this is a figure showing splenic smear showing numerous leishmania bodies into a macrophage. That is a visceral leishmaniasis. So Simpson stain showing this thing. So how we'll manage? Recommended treatment for VL is liposomal amphotericin B 10 milligram per kilogram as a single dose by the infusion. The current guidelines is the recommended liposomal amphotericin B 10 doses total, and it is 4-fold more. Means 4 milligram per kilogram per day on the day 1 to 5 continuously, then every weekly 10, 7, 24, 31 and 38 days. So suppose if liposomal is not available, then you can go with our conventional one, 0.75 to 1 milligram per kilogram per day by infusion daily or alternate day for 15 doses. The combination of 10 days of intramuscular paromycin 11 milligram per kg or with the oral one, oral 10 days of maltefosine, or you can give with the after meal. So this is a table showing how to give it in 2 to 11 years, less than 25-50 milligram, 25 to 50 and more than 50. We have to give it for 28 days if when there is a oral one. This is the current guideline. Post Kala-Azar dermal leishmaniasis, again the dose is for the adult for 25 to 50 BD for 12 weeks. Here, liposomal is half dose, 5 milligram per kilogram per day, 2 times per week for 3 weeks, so 30 milligram. Previously, it was 40. And if we want to give the simple one, then 1 milligram per kilogram over 4 months, so 60 to 80 doses. These all have their own complication, renal toxicity, and we have to monitor. Cutaneous, we can give intralesional antimonials, azoles, and cryotherapy. The cutaneous leishmaniasis is a skin lesion persists for months, sometimes even years. They develop within several weeks or months after the exposure, but occasionally appear in the first year later. These are the papule to nodular plaque to the ulcerative lesion with a raised border. The border is raised and central there is a depression. Characteristic of HIV-related visceral leishmaniasis seen in 2 to 12% of the patient with HIV leishmania co-infection. Mucocutaneous HIV appears in 2 to 3% of all cases of HIV leishmania co-infection. All the leishmania species can cause mucocutaneous leishmania lesion. Although the nasal septum and soft palate are usually affected by the mucocutaneous leishmaniasis, it can be primarily a lesion or it can be somewhere else and appear as a metastatic type of the thing. So in this case, even nasal biopsy specimen can be taken. So this is all regarding the leishmaniasis, hepatitis B, hepatitis C, do when we have this type of the co-infection, when we are having a HIV associated thing. Thank you very much, all the listener, for your calm and listening. If any queries, we can, if time permits, we can discuss at present also, or we can discuss later on also, whatever the
Thank you
madam
so
says.
much, ma'am.
Thank
Any
you.
questions from the participants? Please feel free to unmute your mic. You can also type in the chat box. Any questions on HIV and co-infections? Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Yes, thank you. It's a post-lunch session, so it was my more responsibility to wake them awake.
No, it's not that. The next session will be held on 29th May from 2 to 3 p.m. and the topic is palliative care. For palliative care, you can refer to chapter number 5.7 of the National Guidelines for HIV care and treatment. Ma'am, we'll just quickly run the feedback form.
Okay. Namaskar and thank you.
The feedback form is now visible on your screen. Participants are requested to please attempt all the 4 questions. Requesting all the participants to please attempt the feedback form. Once again, thank you, ma'am. And thank you to all the participants for patient listening. Ma'am, we'll conclude the session now.